Good morning, everyone. Welcome to our webcast. It's all in your head. Today's topic is traumatic brain injury, and before I pass it on to Dr. Swingle, I will give you a brief summary of his background. Dr. Swingle was titular full professor of psychology at the University of Ottawa prior to moving to Vancouver. Fellow of the Canadian Psychological Association, Dr. Swingle was lecturer in psychiatry at Harvard Medical School, attending psychologist at McLean's Hospital in Boston, where he also was coordinator of the Clinical Psychophysiology Service. Dr. Swingle is registered psychologist in British Columbia, certified in biofeedback and neurotherapy. His newest book, Biofeedback for the Brain, was published by Rutgers University Press. The book is available at www.soundhealthproducts.com. We will be taking your questions during our 2 breaks. You can send your questions to us through the chat feature on the control panel on the right side of your screen. Just click the chat tab, type the message, and send. Okay, that's all from me for now. So without further ado, here is Dr. Swingle. Good morning.
Good morning. Well, the topic today is traumatic brain injury, and the issue associated with this is not the more serious traumatic brain injuries, but the one that causes a lot of difficulty clinically are the mild traumatic brain injuries, because there's a very high probability of children in particular being misdiagnosed with all kinds of different things, when in fact what we're dealing with is a mild traumatic brain injury. Now, these are the symptom characteristics associated with mild traumatic brain injury. And if we just go down these, headache and chronic pain and vertigo, difficulty concentrating. Okay, now here when we get into these cognitive processing issues, here's where we have an enormous number of children coming in with a diagnosis of ADD or ADHD. And as you can see, difficulty concentrating, difficulty with attention, difficulty planning. Now, the 2 types of ADD that immediately come to mind here, one is the what I call common ADD, which is elevated slow frequency up over the sensory-motor cortex, and that, the primary symptom associated with that is just daydreaming and problems with sustaining attention. Now, when we get into the other areas, like difficulty with planning, there's another form of ADD, which is characterized by elevated alpha frequencies, 8 to 12 cycles a second up in the front part of the brain. And that's associated with problems with planning, organizing, sequencing, and following through on things. And it's also associated with some basically emotional dysregulation. Now, if we continue down that list, fatigue problems, effort fatigue, we can get into areas if we deal with chronic pain and effort fatigue, we can get into the areas of pediatric fibromyalgia. Then we have the anxiety, depression, and again, people often come in with mild traumatic brain injury, and it's defined as a depression situation. They're given the antidepressants. Sleep disturbance, very common, and I'll show you later on some of the severe sleep disturbances we can get with traumatic brain injury. Irritability. Irritability, mood swings, and personality changes. Those are the ones that capture the news headlines. Football players, for example, becoming very violent with their spouses. Irritability and marked mood swings. That's associated with injury to in particular, the right prefrontal orbital cortex associated with a head injury. Any one of the motor situations, of course. When you get motor complications, you're much less likely to get a misdiagnosis. and of course seizures, a big issue. Now, if you get a change in appetite in a young female, for example, uh, they're very often to think in terms of eating disorder, when in fact it can be one of the sequelae of mild traumatic brain injury. So it's very interesting to consider these things, and we always consider these things when we have clients coming in for the brain assessments associated with presumed issues such as ADD or ODD or eating disorders and so forth. Now, if we look at the criteria of ADD, and now again, these are the ones we were just speaking about, problems with attention, you can see that, does not seem to listen when spoken to directly. Now, this is interesting because you can have an issue associated with what we call absence seizure, and we get that a lot with kids coming in diagnosed as ADD, inattentive. And what it is actually is a mild absence seizure, where the child seems to be looking right through you when you're speaking to them, and it takes a little longer to bring them back. And it's not so dramatic that it really calls attention to the fact that this may be a seizure. Does not follow through on instructions and fails to finish tasks. This is one of my favorites. You know, this category is such a it's kind of like how long is a piece of string concept. You know, little kids don't follow instructions and they don't finish tasks, and it's amazing how often we medicate normal children's behavior. But in any event, this can also be associated with mild traumatic brain injury. Difficulty organizing tasks. Again, that's one of the primary symptoms associated with mild traumatic brain injury. Loses things, distracted. Now, if we look at the hyperactive side, we can see some of the properties associated with high frontal alpha activity or mood dysregulation associated with when there's something that's affecting the right side of the brain. And these are some data that came up from Jerry Gluck in Florida. And this is a professional football player who had a concussion in 2007 and received no treatment for it. And this is what happens with the dominant frequency in the brain. We'll have a lot to say about that. The dominant frequency in the brain, there are several ways of measuring this, and the way I measure it with my clinical intake is I look at the ratio of fast to slow alpha. But alpha peak frequency, what this is if you look at the frequency from 8 to 12 cycles a second, which is the alpha range, where is the peak of that? And that's what we refer to as the peak frequency of alpha. The faster your alpha, the more efficient the brain. And alpha peak frequency correlates with a lot of things. It correlates with IQ scores. It correlates with good immune functioning, good efficiency. So here we see a very direct relationship between untreated traumatic brain injury and a fairly rapid decline in brain efficiency. This becomes really problematic for the aged. When folks get to be my age, you have to watch age-related decline, and declining alpha peak frequency can be an age-related issue. And head injury accelerates that process, and I'll show you a slide of that a little later on. And the statistics that elderly can expect to fall at least once or twice a year. So, and if you jar the body, you're going to have, or the potential for, a mild traumatic brain injury. how do we look at these things? Well, one of the things we've discovered is that most of the systems that we've been using to detect it are no good. Now, this is MRI and CAT scan, and you can see this comes from the journal Rheumatology. Traumatic brain injury often cannot be detected with these procedures. We find that it's less than 25%. Neither CAT scans nor MRI findings predicted neurocognitive deficits soon after the injury or at one-year follow-up. So there's no relationship between what they find on the CATs and the MRIs being useful for determining what kind of deficits you're dealing with. And early imaging findings were not predictive in terms of clinical outcome as well. So we can get rid of this notion that if you suspect a head injury, you should rush the child off for MRI or CAT scan. You need functional measures. Now, functional measures, PET scans, and functional MRIs are more efficient at finding potential problems in terms of how the brain is functioning. Of course, the most effective one is to use a quantitative EEG, which is what we do, of course. Now, this is an EEG. What we're looking at here are topographical representations of how the brain is talking to itself. Coherence refers to intersite connectivity. And there's an algorithm associated with how this is all calculated, but it's looking at things like amplitude and phase lag and so forth. It combines a lot of these issues. Now, one of the things that we very commonly find is what's shown in the bottom row here, and that is in beta amplitude. What we find is that there's hypercoherence in the beta frequencies. That is, when one area of the brain starts to become active, it excites the other areas in the brain. One of the things we know is that the risk of seizure goes up markedly with a traumatic brain injury. And one of the factors associated with seizure, of course, is the spreading of excitation, which is exactly what you're looking at here. So we're having a marked elevation of excitation associated primarily on the left side of the brain and in the occipital parietal regions, but you can see it. It also extends up over the sensory motor cortex and up into the frontal cortex, predominantly on the left side. Okay. Now we're also picking up some other things, and this is hypocoherence, meaning that when this area of the brain, when an area of the brain is excited, it should excite other areas with a certain degree of frequency. And these areas are not exciting the other areas as they should. So when we have this level of precision, then we can do a lot to help these clients deal with the sequelae of mild traumatic brain injury. Here's a multiple injury situation. And post-traumatic stress disorder. Now here, what we're seeing is of course, the elevated hypercoherence in the beta amplitudes. Now this is primarily on the right prefrontal orbital cortex area and also in the back left side parietal occipital region. We're also getting a lot of the hypercoherence in the slower frequencies here. Okay, so this pattern, although there are some similarities between this and the one we just looked at, we're also getting some hypercoherence in some of these other areas. Now, these are inhibitory waveforms. In other words, the brain is slowing down, it's becoming less active when you're getting increases in theta activity. So this is a different kind of phenomenon from the spreading or hyperexcitation associated with when beta is hypercoherent. Here's a recent mild concussion, and you can see that if we're just looking at the strength of delta is a very slow wave in the brain, 1 to 3.5 cycles a second. So we're getting a slowing over the left side of the brain, and what we would expect there is that this individual would have some difficulties with cognitive processing or reasoning and so forth. And we're getting some issues associated with the asymmetry, that is the strength of a waveform, so that there are some dysfunctions associated with that, but everything else looks pretty clean. So we know what we have to do here. Therapeutically, we need neurotherapy to improve this condition, that is to decrease that elevated delta activity. And this is also in the delta range, so when we are taking care of that, and you can see the hot spot right here. When we take care of that, we're very likely to improve this problem associated with the asymmetry anomalies. Age-related decline. This is an individual who's 70 years old, and it's 25 years post-traumatic brain injury. And you can still see some of the hyper and hypo connectivity here. So when we are going after this, in addition to dealing with the alpha peak frequency, now you remember that very first slide from Jerry Gluck in terms of what happens with the alpha peak frequency with age and what happens with the alpha peak frequency with traumatic brain injury. So we're getting an acceleration of the decrease in the peak frequency of alpha. That's not shown in this slide. This is only showing some of the connectivity issues that we want to address. And here we're getting some hypocoherence associated with alpha, and we're getting a lot of dysregulation in the beta ranges. Here's a major traumatic brain injury. And you can see here, again, similar to what we've seen previously, that is marked elevation of slow frequency. And in this case, it's all over the brain. Here's delta, very slow, 1 to 3 cycles a second roughly. And here's theta, again slow, 4 to 7 cycles a second. And there's just too much of it all over the brain. So we have a real problem here with the brain functioning, because of the hypoactivity associated with marked elevation of slow frequency amplitudes. Here we have the telltale sign again. Elevated hypercoherence in the beta range that we very frequently find with traumatic brain injury, but we can see other dysregulations as well. So we have a lot of work to do here. First order of business is we have to get this elevated slow frequency under control with neurotherapy. And then we would probably do some work specifically on the coherence factors. But we always start with this, because when you correct the problem associated with the amplitudes, very often you get correlated positive changes in resolving some of the hypercoherence and problems associated with brain connectivity. Mild frontal lobe epilepsy. Now, the reason that traumatic brain injury is correlated with lower seizure threshold is this spreading phenomenon. And here we see it where we have marked elevation of the faster frequencies sitting up over the right, and we have some hyperconnectivity issues. So this is what frontal lobe epilepsy would look like. Again, there was a brain injury here. And the other popular diagnosis, of course, is post-concussive syndrome. And this is after an individual has had a concussion. So what we're seeing here is on the front part of the brain, nothing much seems to be out of line here, so I'm not particularly concerned about that. But you can see here, F3 is the left frontal side of the brain, F4 is the right frontal side, and you can see there are huge disparities here between the right and the left. So theta is 40% lower in the right relative to the left. Individuals that show that pattern are usually depressed. This is usually a depression marker. We're seeing the same thing in alpha, and likewise, this is also a marker for depression. And then finally in beta, when we have marked elevation of beta on the left relative to the right, that's usually a marker for anxiety. Now, this is a direct relation, the direct effect of the impact that this individual experienced. Here's the second part of that assessment. And again, what we're seeing here is in the back of the brain, this individual has a deficiency in the ratio of slow frequency to fast frequency amplitudes. This is a marker for stress tolerance. Now, and we want this up at least around 1.6, 1.8 or so. It's quite a bit under this. Now, the reason I'm showing this slide is one of the complicating factors with our military folks who have had something like a concussion is they arrive on our doorstep with post-traumatic stress disorder. And there are other individuals who've gone through exactly the same thing who don't. I mean, they have the sequelae of the concussion, but they don't have post-traumatic stress disorder. The difference is this, and that is poor stress tolerance that they walked into the battle theater with. So that the same event had a much more marked impact on the person with the low stress tolerance. Okay, so what we're also seeing here is a profound slowing of alpha. Here is the ratio of the intensity, strength of low alpha, 8 to 9 cycles a second, relative to fast. This number, we want below 1.5, and the lower the better. And this person is way, way over that, and the peak frequency is low. So we want this much closer to 9.5 or 10. And there's a correlation, direct correlation between these two measures. So this is the primary factor that we've been talking about earlier about the effect of head injury affecting alpha peak frequency, which is a marker of brain efficiency. We are often vulnerable to that slowing simply by getting older, and if we add a head injury on top of it, then folks my age with a head injury are at profound risk for alpha slowing and for poor cognitive processing.
Okay, our fused Q&A section. Again, if you would like to send your, if you'd like to get your questions answered, send them through the chat feature on the control panel. Dr. Swingle, with a mild TBI sports concussion, is it necessary to do a full QEEG, or will the clinical Q be sufficient?
No, you want to have a full Q. And there are a few exceptions to that. Excuse me. The fact that you come in for treatment announces to us that there's a problem. And a lot of it has to do with the nature of the injury, but unfortunately, it's very difficult to get a handle on how much brain injury there is relative to the nature of the accident. Head injury is cumulative, so if you've had a few knocks playing football or whatever, then you have a fifth one, which didn't seem to be very significant at all, and you have profound neurological impact simply because it's cumulative. So to be on the safe side, we want to do a full cue. There are a few exceptions to that, but in general, you want to look at connectivity.
So head injury can cause blunting of alpha?
Yes, blunting of alpha is a different issue. Blunting of alpha refers to something that is affected by mostly emotion. Now, this is something that happens whenever we have a head injury. Usually there's an emotional content to that. If you've been in an automobile accident, you were frightened that you were going to be seriously hurt or lose your life and so forth. And that's an emotional component that's very different than the functional effects of the brain injury. So, yes, with traumatic brain injury, we very, very frequently find the emotional blunting of alpha. And for those folks in the audience who don't know what we're talking about here, if you're measuring alpha, 8 to 12 cycles a second, at a location in the back of the brain, there's several spots we can measure this. When you close your eyes, there should be a big jump in the strength of that. And when you open your eyes, it should drop like a stone. Now, we look at that to look at brain efficiency. But if you close your eyes and alpha doesn't move very much, that's usually a marker for having been exposed to a severe emotional stressor, an emotional trauma. And, of course, head injury is usually an emotionally traumatic event, so sometimes we see those combined.
My brother recently had a heart attack and was without oxygen for 7 minutes. This was followed by a stroke in hospital. Would there be any way to detect whether this would happen or any way to prevent this from happening? It seemed to come as a big surprise to everyone there, and they didn't actually know that it had happened, except that the family pointed out that there was no movement on the right side of his body and some movement on the left side.
The ability to predict whether you're going to have a stroke, at least with this technology, no. At least not in my experience. The fact that you're experiencing something like that, yes, that's measurable. And also the legacy, the post-stroke effects on brain efficiency, yes, that's measurable as well. There, by the way, you're more likely to have identifiable structural changes in the brain, so the MRI and CAT scans often can pick that up. But from our perspective, we're much more concerned with the functionality of the brain.
Okay, and we'll take one more question, but we'll get to the rest of your questions at our second Q&A section. I have PTSD and past TBI. I've also have chronic pain from several other accidents in the past that weren't head injury related. Is my current chronic pain level exasperated by the original TBI?
Yes, I would think that's exactly the case. Now, the other issue is if you've had other accidents, but they weren't identified as head injury, anytime the body takes a severe jolt, it's likely that you're going to have some brain implications simply because of the way the brain is sitting in the cranial vault. That's certainly true with impacts like falling, for example. Even if your head is not directly hit, possibility for head injury, particularly in the front part of the brain, the frontal preorbital cortex region, is very, very vulnerable to mild traumatic brain injury that may recover after a month or so. But people get irritable, they have mood changes, things of that nature.
Thank you, Dr. Swingle. Let's move on.
Okay. Now, this is severe traumatic brain injury, and there are lots of things we want to look at here. First of all, this is the topographical representation of the strength of brain waves in each one of these 1 Hertz bins. So this is the delta low theta range, and you can see that there's marked elevation of slow frequency virtually all over the place here. Now, this is the same client, and what we're looking at is coherence. And you can see that all of these are marked in blue, which is hypo coherence, and the brain's not talking to itself very well in any of these areas. And it's primarily in the frontal region. Okay? So the brain's not talking to itself very well, and we have marked elevation of slow frequency amplitude, slow frequency amplitude, primarily, again, frontal regions. Okay? Now, if we're looking at asymmetry, you can see again that the brain's not talking to itself very well. Now, what amplitude refers to is if I'm getting an increase in the strength at one area in the brain, what am I getting at another area? So if it goes from, let's say, 10 microvolts to 20 microvolts at one site, what does it do at an adjoining site? Now, we know what it should look like. In some cases, if one area of the brain is excited, it should excite another area. Now, there are various ways of measuring that, and amplitude asymmetry, of course, is one of them. And you can see that the brain's not functioning well at all here. We have a lot of hyper and hypo amplitude asymmetry associated with this head injury. So we have elevated slow frequency all over the brain in the 1 through roughly 6 cycles a second range. We have a problem associated with the coherence. That was the previous slide. Here it is here. So the brain's not talking to itself very well. And then we have this marked dysregulation in amplitude. Okay, now I'm going to show you what sleep looks like with an individual who has that exposure. One of the issues associated with traumatic brain injury is you get marked dysregulation in sleep. The particular client I was showing you had a long history of coma post-injury, and it is a serious injury. Now, this is what efficient sleep look like. A person sleeping about 7 hours in total. It took them about 10 minutes to fall asleep. You should fall asleep within 15 minutes. And deep wave sleep, and that is when the body is healing and restoring itself. You need about an hour of deep wave sleep. You need about 2 hours of REM. And now REM, rapid eye movement sleep, serves 2 extremely important functions. Function number 1 is you do your own psychotherapy during REM. This is the time when you're processing all of the emotional stuff that went on during the day and putting it into proper perspective and so forth, or letting it play itself out. The second very important function of REM is that's the brain's time to do its organization, filing, and house cleaning. So whatever you've learned during the day, that's when the brain is filing it all away and putting it in the appropriate file cabinets. Now, we see a lot of students who their complaint is, I studied and studied and studied, and the next morning it wasn't there. The problem is REM sleep. I mean, assuming they go to sleep. The problem is REM sleep. Now, this is what efficient sleep should look like. A couple of awakenings, a nice period of REM, wake up, out of bed, okay? In bed by 11, up by 6. Couldn't be better. Sleep around 7 hours, anywhere from 6 to 7 is perfect, provided you have good sleep architecture. And good sleep architecture, again, the primary thing is an hour of deep, 2 hours of REM. This is the client we were just looking at. His total sleep time is about 4.5 hours. His total bedtime is about 7 hours. He's awake 35% of the time. It took him 50 minutes to fall asleep. He's very deficient in REM, marked elevation of deep wave sleep. So this is a cycle in which awake and then bam, right into huge deep wave sleep, right out of deep wave sleep into full alert, and out of alert fall right into deep. Now his daytime behavior looks like this as well. He'll be functioning and dealing with you, and then all of a sudden he just can't stay awake, and boom, he falls into sleep pattern. And what we do with our sleep assessments is we take multi-night samplings. So it's far more accurate than the sleep lab stuff that they do in hospitals, for example, in which they take a 4-hour picture of sleep under strange environment conditions. We do sleep assessments at least 4 nights, and it's a wireless EEG device that you're using, not a movement device. So here's his second night. Took him a half hour to fall asleep. He slept about 4 hours and 20 minutes. He had almost no REM. He had, again, almost 4 hours of deep. And look at the pattern here. Again, that same thing. Awake, and it's almost like falling off a cliff into a coma-like state. Here it is again. He's picking up a little REM here. Again. Now this is, I think it's 8 nights that we're looking at, and it all looks the same. So the fact that he's daytime dysregulated, of course, no surprise to anybody. One of the things that we very frequently see with traumatic brain injury is fibromyalgia. And an injury is one of the primary contributing causes for fibromyalgia. And what you're getting there is widespread soft tissue pain in multiple diverse painful areas that tend to shift around. So as you remember from the list of characteristics associated with mild traumatic brain injury, you're getting those. Sleep disturbance, almost all fibromyalgia clients have sleep problems. Frequent awakening, non-restorative sleep, and then a lot of comorbid conditions, and then conditions that look like ADD. This is the fibrofog that they always complain about. Stress exacerbated. The cause is, again, the traumatic brain injury, emotional trauma, viral infection is huge, a huge contributor to the development of fibromyalgia and, of course, stress. And it has a very definitive pattern associated with it. And you always, always, always have frontal lobe implications in fibromyalgia. And this is what it looks like if you're just looking at raw numbers coming off the screen when you're doing an assessment. And we're seeing a couple of things here. And this is what we're seeing with this person. First thing we're seeing is we're seeing complications in the front part of the brain, primarily on the right side. So you can see that on the right side, there's a marked elevation of fast frequency. Now that's a marker for depression. We also tend to find a lot of slow frequency on the right relative to the left, and that's what you're seeing here. So that's another factor that we almost always see in fibromyalgia. Marked elevation of faster frequencies in the right relative to the left, that's depression. Marked elevation of slow frequencies in this area as well, and that's the one associated with fibromyalgia and chronic fatigue. Now, my guess is that one of the contributory factors associated with fibromyalgia is a traumatic brain injury, which is very common, that's affecting the right side of the brain more so than the left. I don't have much evidence for that, but that's the way the data look when we're doing this clinically. The other thing that you almost always find, in fact, you always find that I would say, is a deficiency in the back of the brain. So you have very, very poor stress tolerance, and stress is one of the contributing factors to fibromyalgia. The other thing that we often find with fibromyalgia is hyperactivity of a region in the brain that's sitting in here, the anterior cingulate gyrus. And that's fretting, getting something on your mind, you can't get it out, and it exacerbates the stress factor. And this is, Picasso did this, what we were just looking at here, and that is, excuse me, we have elevated beta on the side of the brain, elevated theta, and elevated alpha. So there's your marker for fibromyalgia. Elevated activity in this region in the brain, and that's the anterior cingulate gyrus. Get something on your mind, you can't get it out, and poor stress tolerance.
Okay, we are now going to get to the rest of the questions. Dr. Swingle, when you do TDCS, and if you don't mind, Dr. Swingle, to explain what that is for other people, where do you place cathode, given that an anode should be placed on the place where the injury is?
TDS is direct current stimulation, a DC current, and it's a procedure that is an FDA compliant protocol. Whether you're using the positive or negative depends on whether you're trying to excite an area or not. You don't always use negative on an area. It's one of the popular misunderstandings. It's also a problem we have with individuals who are using direct current without proper training. If you want to excite an area, you use the positive or cathode. And if you want to decrease, you use the anode. Now, where you use your reference is usually on a shoulder or a wrist, something of that nature. And basically what you're doing is you're passing very, very, very low amperage current through an area of the brain. There are a lot of different procedures that use this kind of protocol. There's a procedure referred to as LENS, which is low electrical stimulation in the micro Tesla range. which is we find very effective for the treatment of head injury. There are other procedures that use roughly the same kind of thing. Now, there are other forms of stimulation, such as cranial electrical stimulators, which generally are used on the ears or mastoid process, and that's an AC operation in which you're getting current changing in polarity. But the direct current, for example, in this case, if I wanted to quiet down the anterior cingulate, then I would be placing it up in the front midline of the skull, and I would be using the negative electrode in order to try to quiet that area. There's a change in polarity when the current goes through the skull. That's why you're using negative.
I'm suffering from persistent post-concussion symptoms. The concussion, my fourth, happened about August 2011. My symptoms are headaches, nausea, effort fatigue, and anxiety. I am currently a client but just starting my treatments. What typically does the treatment do for my condition?
Well, the best of all possible worlds is it gets rid of all of the symptoms. A lot of it depends on severity and any pre-existing conditions you might have had. So in terms of vertigo, the vertigo is very often associated with complications of the vestibular system. And if you've had a severe injury, sometimes you can get the crystallization problem associated with that. So some of the physiotherapy that you may be getting now for that would be helpful. And also we do some physiological work here using wireless EEGs. So the area of the brain associated with a particular activity is actually being treated while you're doing things like walking in parallel bars and so forth. So, the very first thing that people usually notice when they have post-concussive syndrome is that there's a change in mood state. I'm talking about the positive changes now associated with treatment. Then you start to get improved what we call body integrity, and that is where the vertigo and instability and insecurity associated with ambulation start to improve. And then you start to get cognitive improvements.
Okay, thank you. We'll take one more question looking at the time. Are there exercises that can be done to get the brain working better after TBI?
Oh, yeah, sure. Exercise, and I don't mean necessarily vigorous stuff, just a nice, fairly fast walking. The second is reading. Now, very often you'll find that cognitive effort really is extremely tiring, so that you have to take it in slow bits. Read a little bit a few times a day and just gradually increase the time. In any cognitive challenge, what you want to do is stay off the sofa and turn off the TV, and get yourself engaged in other things. That can make a huge, huge difference.
Thank you, Dr. Swingle. Let's continue with the presentation.
Okay. I consulted for this case a little while ago. This is an 11-year-old boy who was in an accident a year ago, suffered head injuries. He had a swelling of the right temporal or parietal lobe. X-ray showed hairline fracture. CAT showed some blood clots. His last CAT showed that everything was normal. Okay, he gets dizzy, weak, swelling in the neck, and so forth. Has difficulty focusing, gets headaches when he tries to read. Now, there's that cognitive challenge issue that I just mentioned. When you have a head injury and the brain is not functioning efficiently, cognitive effort is really problematic and gives rise to huge fatigue, headache, and so forth, not uncommon. Poor sleep comes with the territory again, and he gets frightened very quickly. So there's your right prefrontal cortex injury. Here's what it looks like. We have a blunting of alpha. Somebody mentioned that before. That should be above 30%. So, the child is carrying what we call a trauma marker associated with having been exposed to a frightening event. Back of the brain, also the trauma marker, and here's the poor stress tolerance. Remember we said in the back of the brain we want to see those numbers up at least 1.6, and this is a very young child, 11. This should be huge. This should be sitting up in the range of 2. So we know that this child has a genetic predisposition for poor stress tolerance, so we're building a perfect storm here. Here's the impact factor, okay? Here's the right side of the brain, and we're having these major disparities in terms of there's a marked excess of beta on the right, marked excess of alpha, and marked excess of theta. So we have the mood dysregulation, problems with cognitive processing. And here's the back part of the brain. And what we're seeing here, happily, is a very, very, very bright child. So if you look at the density marker, we want it below 1.5. He's way under that. And look at this alpha peak frequency. You bottle that, you'd make $1,000 a day just selling drops of this stuff. Anything above 9.8 or so is really good, and he's really up there. Okay, so the treatment of this is very straightforward. We want to get the frontal lobes balanced here. We want to give him more stress tolerance, take care of that easy frightened business and so forth. And whatever this is, we want to release it and help the child process that. Now, when we improve sleep, he'll be doing that himself, in addition to our offering the parents some suggestions about how they can comfort this child, make him feel less frightened and more secure. Injuries of this nature are very frightening to children, of course, because it just shatters their concept of safety and security. The number of neurofeedback treatments that is required to deal with traumatic brain injury obviously is a function of initial symptom load. What we mean by that is how much damage is there, and you can tell that by the difference of the symptoms, by the array of symptoms, I should say. Cognitive issues, sleep issues, pain issues, emotional dysregulation, and so forth. It correlates also with improvement, obviously. And finger temperature is an interesting one. That's measuring how relaxed the body is in terms of peripheral blood flow. The most important thing, I think, is something that John Walker, he's a board-certified neurologist in Texas who does neurotherapy. What he has found over the years in terms of working with traumatic brain injury, when I went to school, what we were taught in medical and graduate school is just wrong. I mean, there's a lot of it that's just wrong. And one of the things we were taught is that the legacy associated with traumatic brain injury, that is, after 18 months, game over. You're not going to get very much improvement after that. And what John has shown is many, many, many years post injury, you can get significant improvement if you do targeted neurotherapy directed at the nature of the functional dysregulation. So he had clients anywhere from 19 to 40 sessions, and these are people that were up to 5.5 years or so after the traumatic brain injury. And 88% had at least 50% improvement in symptoms. And John published this some 11 years ago. Okay? And since then, our ability to treat these conditions has markedly improved. So this notion that you're 25 years post-injury that you have to live with is just not true. period. This is neurotherapy for stroke. And this data came from the late Tom Budzinski. This is before neurotherapy. This is after about 8 sessions, and this is when neurotherapy was finished. And you can see profound change in the neurology here. Are we going to give this a try?
Let's give it a try. We are just going to rearrange a few things here, so stand by, everybody.
What I want to play for you is the voice of a woman who had a traumatic brain injury booking an appointment in my office at Harvard before she had any treatments. And then she's booking an appointment after she had about 11 treatments. So we're going to see if we can get this to work. We can't do it via the computer, so we have to, high tech. We're going to go over to an old CD player. So let's see if we can do it. The first one that you will hear is the woman before treatment. Now listen, if you can, to the quality of the voice and her ability to enunciate. And then the second one will be after she's had the treatments. Okay, let's see what we can do here.
I'm not going to be able to make a 9 o'clock appointment. We're still figuring out our kids for I'll call you guys and make appointments for next week. Bye. Dr. Flynn, listen, I'm calling to make an appointment for next week, Thursday at 11 o'clock. If that's not good, could you give me a call back and let me know which would be a good time? Thank you.
Now, hopefully you were able to hear the very profound difference in that clarity and articulation. So that's what neurotherapy can do. And one of the first things we do see often in people who have speech difficulties associated with traumatic brain injury is the speech clarity improves. And the way we treat this, for folks who don't know, is we set it up. We have a wire on top of the head measuring brain activity. And for kids, we use things like this game. Doing what we wanted to do, the rocket ship starts to move. And if the brain stops doing what we wanted to do, it stops. And if it does what we want it to do, it goes, and it stops. Adults very often like to see the raw signal, and what this person is doing is controlling the size of that column right there, trying to make it stronger. Brain driving, here the computer does the work so that we are stimulating acupuncture points and presenting light and sound to drive the brain, and so we can have lights go on when the brain is in certain states that we're trying to either increase or decrease, sound, and of course electrical stimulation of acupuncture points. And this is something I mentioned earlier. We can have a wireless device so that we are recording brain activity while the individual is ambulating, and we have a lot of different physiotherapy equipment and people who are trained in physiotherapy doing the treatment for us. And this is bipolar condition of alpha slowing in a 70-year-old person who had 3 full anesthetics and was on oxycodone, which markedly affects the alpha peak frequency. And this is the peak frequency. We want this value below 1.4 or so. This is the brain driving. Here's the alpha density, and that's much too high. And after one session, you can see that we brought it down into normal range, and that's using very aggressive brain driving procedures to get the brain sharp. And I have a number of different markers for this. This is neonatal hypoglycemia, in which the child had very significant deficiency of energy, basically, food. And you can see the damage that was done here in terms of function, so we know exactly what to do with regard to it. And this is a degenerative brain disorder, and this has infantile spasms. Now, you're not going to cure degenerative brain disorder. It's a fatal disease. Fatal condition, I should say. But the parents wanted a relationship with the child. They did not want to sedate this child until the child died. They wanted to have a relationship with the child. So we went after getting the seizures under control so they wouldn't have to use anti-seizure meds. And the child was alert, many seizure-free days, regained partial use of the arms, and died 16 months after treatment. All kinds of ways to deal with this stuff. This is the Army at Walter Reed doing art therapy, and this is some of the images put together by soldiers who had traumatic brain injury and post-traumatic stress disorder. This was 60 Minutes, by the way, did this stuff. What happened? Oh, there we go. Okay. Good. And this is the other one I wanted to show you. This is an individual who felt he had to be camouflaged. Okay.
Okay, I'll quickly take it from here. Biofeedback for the Brain is the book I mentioned at the beginning. If you are interested in learning more about neurotherapy, this is the book for you. It's available at soundhealthproducts.com. Dr. Swingle has written another book, Basic Neurotherapy, which is a guide for clinicians. It leads them through the procedures for evaluating and treating patients with a wide range of disorders. It's also available at soundhealthproducts.com. And we have many educational offerings here at Swingle Clinic. These include public lectures, webcasts, online classes, professional trainings, and workshops. Many of these opportunities can be found on our events page at swingleclinic.com. Dr. Swingle also offers training through Biofeedback Foundation of Europe. You can visit their website at www.bfe.org to see all the offerings of Dr. Swingle's webinars and online courses. The professionals who complete the courses can get up to 42 hours of continuing education. And we only have few spots left for our next Dr. Swingle's Clinical Q and Brain Driving workshop from June 21st to 23rd. It will be the fundamental workshop, and it will be followed by the advanced workshop from October 4th to October 6th. For more information, you can contact me by email at rita@swingleclinic.com. Every second Friday of the month, we offer online grant rounds. These are web conference sessions of case reviews and discussion of treatment strategies. Great learning opportunity for professionals. And another workshop we have scheduled for this year is Optimal Performance Workshop with Hiroko Demichelis, who is leading our Precision Neurometrics division. This two-day workshop will focus on methods of assessment of neurological, but also physiological aspects, and the participants can expect practical knowledge of how to use these assessments to develop protocols using EEG biofeedback, EMG, skin conductivity, peripheral temperature, and heart rate variability training to lead clients to enhance performance. It is scheduled for September 7th and 8th. And we have public lecture coming up with Dr. Swingle, and it is hosted by Amica Center for Retirement Living. It will be conducted on Friday, July the 12th this year at their location. You can see the address on the slide. If you are interested in attending, please contact Amica directly at 604-921-9181. And that concludes our webcast about traumatic brain injury. We will be back on June the 8th with Dr. Rick Bradshaw, who will talk about career counseling that we offer here at the clinic. Have a great weekend, everyone. We hope you enjoyed it. Bye-bye, and thank you, Dr. Swingle.